diagnosis of pulmonary diseases. Different types of pulmonary diseases that you know that for the differentiation, that I already told that the obstructive and restrictive lung disease. We know that obstructive lung diseases like bronchial asthma and the restrictive lung diseases like paralysis of the chest that which cause the problem with the inhalation and all. So these two types of diseases we can differentiate with use of this pulmonary function test, and also monitoring the progression of the disease, and also evaluation means evaluating the treatment efficacy that we can also assess through this pulmonary function test. Assess the severity of the disease. I already taught different types of severity of the disease that we can also assess through this pulmonary function test, and respiratory status before anesthesia that we are providing that before any major surgery at that. Before that, we will assess the pulmonary function test, and also physical fitness. Some person means for some there like deep diving, and also for military forces like that, we will assess the physical fitness that we will assess the pulmonary function test. So the classification, major classification and ventilatory function test, test for diffusion. There are different types of classification that depends on ventilation that we will do this ventilatory function test. Test of diffusion, that is diffusing capacity of the respiratory membrane that we will analyze, and test the ultimate purpose of respiration and test during exercise. So among all these tests, our topic comes under the ventilatory function test. Here, assessment of the expansion of the lungs and the chest wall. Here we are mainly concentrated on the expansion of the lungs and the chest wall, and assessment of the obstructive and restrictive ventilatory defect. So it can be assessed through the major portion that we are going to deal with the measurement of the lung volumes and capacity. Through the measurement of lung volumes and capacities, we will assess the ventilatory effect of that the pulmonary function. Mainly the pulmonary function test analyze or assess the physiological status of the lungs, the function of the lungs and the airways that we will assess through the pulmonary function test. So common pulmonary function test includes spirometry, and then diffusion capacity of the lung with the carbon monoxide, 6-minute walk test, fractional exhalation of body plethysmography, cardiopulmonary exercise test, force different types of pulmonary function tests. And among these, our topic is the means lung volumes and capacity. So it comes under the spirometry. Pulmonary function test is the spirometry. And here, what is spirometry? This is the assessment of the lung volumes and capacities by using simple spirometer or computerized spirometer. But nowadays we are mainly using the computerized spirometer. So while we are analyzing the graphical representation, that is known as the spirogram. Just like told that is ECG, electrocardiogram graph like that. എല്ലാവരും കേട്ടിട്ട് ആകെ ഇരിക്കുകയാണ്. ഇത് വളരെ സിമ്പിൾ ആണ്. അതുകൊണ്ട് ഞാൻ രക്ഷപ്പെട്ടു. ഹക്കീം ഇവിടെ ഇരുന്ന് ഇങ്ങനെ ചിരിക്കുകയാണ്. അപ്പോൾ ഇത് വളരെ സിമ്പിൾ ആണ്. അതുകൊണ്ട് വേഗം നമുക്ക് പോവാം. Assessment of the lung volumes and capacities through the spiral. And the while inhalation, the positive deflection, that is inhalation, that is upward movement, and exhalation is the downward movement, deflection. So lung volumes and capacities that we are assessing through this spirometer. What is the lung volume? Actually, lung volume is the volume of air breathed in and out by a subject in different phases of respiration. Inhalation on the exhalation on the different phases of respiration. The amount of air breathed in and out by a person at the of respiration, different volumes are tidal volume. Next is inspiratory reserve volume. In a UG class, we have 5 mark in the question pulmonary lung volume and capacities. As സമയത്ത് അത് മാത്രം പഠിച്ച് നമ്മൾ പോവാണ്. അപ്പോൾ lung volume, tidal volume, inspiratory reserve volume, expiratory reserve volume and residual volume. These are the important lung volumes. Next is the capacity. Lung capacities are the respiratory capacity. What is the lung capacity? Lung volume is the amount of air breathed in and out in different phases of respiration. That is lung volume. A combination of 2 or more lung volumes are called capacity. 2 or more lung volumes. But we are taking the lung volumes 2 or more, then it is the capacity. Different types of capacity. Inspiratory capacity. expiratory capacity, vital capacity, functional residual capacity, and last one is the total lung capacity. Clear? So before going into individual lung volumes or capacities, the main division static and dynamic lung volume and capacities. Static lung volume and capacities and dynamic lung volume and capacity. What is the difference? In static lung volume, the time factor is not considered. The rate of change of volume per unit time is not considered in the static lung volume. So we are simply sitting here taking that volume without considering the time. So the static lung volume and capacities are not timed. But in dynamic lung volume and capacities, it is timed. That is the rate of change of lung volume per unit. What is it? Time. For time is considered here. Dynamic. That is the basic difference. Static is not time and dynamic is time. But in clinical practice, this dynamic lung volume and capacities are more important, clinically relevant, because with the time that we are analyzing the different airflow rate and all, so we can differentiate the obstructive lung disease and restrictive lung disease by analyzing this dynamic lung volume and capacities. Clear? So the normal static lung volume examples are tidal volume, inspirator reserve volume, and then vital capacity, etc. are the static. We are not considering the time. Just inhaling, according to the instruction, he will take the deep inspiration and deep expiration only. We are not considering the time. That is static. Dynamic with the time, timed, and then examples are forced respiratory volume, and then timed vital capacity. These are all the dynamic lung volume and capacity examples. So come to the static lung volumes. Tidal volume, I told already. Tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume are the common volumes, static lung volume. So first come to the tidal volume. That we all know that the tidal volume. What is tidal volume? That we are using now. Simply sitting and take normal inhalation and exhalation. That is the amount of air breathed in and out during a normal quiet breathing. That's simply sitting and we are taking inhalation and exhalation. Normal amount of air that which we are taking in and out during quiet normal breathing. That is tidal volume. So we can see that this is the spirogram. This is the graphical representation of spirometer is the spirogram. Here we can see that red marking that we can see that tidal volume is 500 ml. Tidal volume 500 ml. Then the upward deflection is the inhalation and the downward is the exhalation. We can see this one, that red mark. You can see the tidal volume. It is the volume of air breathed in and out during normal quiet breathing. Okay. Next, inspiratory reserve volume. Inspiratory reserve volume. So what is inspiratory reserve? Tidal volume we know. So the maximum amount of air that can be inspired at the end of normal tidal inspiration. In spirogram, we will get that picture. Then it is very easy. Here, after the normal tidal inspiration, here maximum volume of air breathed in with the maximum inspiratory effect from the tidal inspiration. Clear? The volume of air that can be inspired at the end of normal tidal inspiration. Here we can see inspiration, expiration. So here at the end of normal tidal inspiration, the maximum volume of air that is breathed in. So along with the additional volume of air that is breathed in. It's clear. Additional volume. Normally we are doing the tidal volume. So we are instructed to do a deep inhalation. That is normally along with that additional volume of air that is breathed in with the maximum inspiratory effect. That is the inspiratory reserve volume. That is 3000 ml. Normal is the 3000 ml. Clear? additional volume of air breathed in after a normal tidal inspiration. Don't confuse. Next is the expiratory reserve volume. Here the same thing in the expiration. The maximum amount of air that can be expired out after normal tidal expiration. That is the difference. Inspiratory reserve volume is the after the normal tidal inspiration we are taking the additional volume. But in the expiratory reserve volume, the maximum expiration takes place after the normal tidal expiration. That is the downward reflection that we can see. That is expiratory reserve volume. That is normal is 1000 ml. So next, the last one is the static length volume. Comes the residual volume. What is the residual volume? After the forceful expiration, some amount of air that is remain in the lungs. So the amount of air that remains in the lungs after forceful expiration, that is the residual volume, and it is normal 1200 ml. 1.2 liter is the normal residual volume. Clear? Up to this is clear. So these are all static length volume that we are assessing only the volume without any consideration of the time. It is a difference. Static length volume. Next, come to the static length capacities. Static length capacities are the combination of two or more length volumes that we can see. Inspiratory capacity, different capacity. First, we will look into inspiratory capacity, the maximum amount of air that can be inspired at the end of normal tidal expiration. Don't confuse. Inspiratory capacity is maximum amount of air that can be inspired at the end of normal tidal expiration. Clear? At the picture we can see the normal tidal expiration, the maximum volume of air that can be inspired. That it includes tidal volume and inspiratory reserve volume. Clear? So tidal volume plus inspiratory reserve volume is almost 3500. Normal 3000 plus tidal volume is 500 ml. So 3500 or 3.5 liter is the inspiratory capacity. Next is the expiratory capacity. In expiratory capacity is the maximum amount of air that can be expired out after normal tidal inspiration. That is the difference. So it includes tidal volume plus expiratory reserve volume. Tidal volume is 500, then expiratory reserve volume is 1000. So expiratory capacity is 1500 ml. The third one is the vital capacity. We already know vital capacity. Most of it we are assessing the vital capacity of the means at the time of taking exercise and before and after. So vital capacity, what is it? Maximum amount of air that is breathed out forcefully after a deep inspiration. Both inspiratory and expiratory effort is there. We are taking maximum effort. After a deep inspiration, we are taking the maximum inspiration and then expired forcefully. So the maximum amount of air that is expired out after a deep inspiration is vital capacity. So it includes, you can see, tidal volume is there, then inspiratory reserve volume, the maximum volume of air breathed in after normal tidal inspiration, and then expiratory reserve volume. So it includes tidal volume, IRV and ERV. So total it will become 4500 ml. That is the vital capacity. Next comes under the functional residual capacity. That the volume of air remaining in the lungs after normal tidal expiration. That is the functional residual capacity. So here after normal tidal expiration, already that there is residual volume is there. Along with that, expiratory reserve volume is there. Expiratory ERV plus RV residual volume is the functional residual capacity. It is not used for means, but it is there. That is the functional residual capacity (FRC). ERV plus RV residual volume, that is actually 2200 ml. 2.2 liter is the functional residual capacity. And last is the total lung capacity. It includes all the lung volumes. Volume of air present in lungs after a deep inspiration. So it includes all the volumes like a tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. It includes all the volumes. So it is almost 5,700. We will call it round up to 6 liters. 6 liter is the total lung volume. Clear? So next come to the dynamic lung volume and capacity. What is the dynamic already told? Here we have time. So in this clinical point of view, this dynamic lung volume is very, very important. Here mainly forced vital capacity or timed vital capacity, forced respiratory volume, respiratory minute volume or minute ventilation, maximum breathing capacity, that is MBC or maximum ventilation volume, peak expiratory flow rate. These are the some dynamic lung volumes and capacity. So first comes under the forced vital capacity. Here we can see the volume of air that can be exhaled forcefully and rapidly. The word is important. Forcefully and rapidly after a deep inspiration. The same, almost the same with the vital capacity. Here, vital capacity is the maximum force of expelled air after a deep inspiration. That is vital capacity. Here, forced vital capacity. So it is exhaled forcefully and rapidly. The only difference is that in vital capacity they are doing their own time, but here we are giving in a time. We are assessing with the time. So we are using a spirometer and can be timed by recording the vital capacity on a spirograph. So it is timed vital capacity or forced vital capacity. So here we will have three components of total vital means timed vital capacity that comes under the forced expiratory volume. Forced expiratory volume is having three timed vital capacity is having component. That comes this forced expiratory volume. Here we are analyzing the airflow rate. Clear? Timed and the airflow we are analyzing. That is volume of air which can be expelled forcefully in a given unit of time after a deep inspiration. We are analyzing in the proper time. That is first second, second second, and third second. We are analyzing the expiratory rate. It's airflow. That is FEV1, FEV2, and FEV3. Here, forced expiratory volume 1 means FEV1 means maximum volume of air breathed out in the first second of a forced vital capacity. Clear? We are taking a deep breath and the point is there, and after that we are expiring with the maximum force rapidly. We are instructing the patient. So we can divide this first second, second second, and third second. That's the maximum volume of air that is breathed out in the first second. The end of first second is FEV1. In the end of second is the FEV2, post expiratory volume 2. And at the end of third second is FEV3. So at the end of third second, all the volume of air that is breathed out. 3 seconds it will take. So we are assessing that how much volume of air is expelled out in the end of first second. That is FEV1. It is very, very important for differentiating with the obstructive and restrictive lung diseases. FEV1 and FVC, forced vital capacity. Clear? FEV2 means at the end of 2 seconds. So normal is FEV1 percentage is 83%. So what do you mean by 83%? Here at the end of first second, 83% of volume of air is breathed out with the forced vital capacity. Forced vital capacity is there. So in the end of the first seconds, how much volume of air is breathed out that we are analyzing. That is the percentage of FEV1 is normally 83%. FEV2 at the time end of second 94% of vital capacity that will expire. And the third FeV3, 97 to up to 100% volume of air will be breathed out. Clear? So it is important. So we can see here, forced respiratory volume 1, that is 4 liter. In a normal healthy person, we can assess forced vital capacity is 5 liter. Okay, almost 5 liter forced vital capacity. And FeV1 is 4 liter. So what is the FeV1 divided FeV1 percentage that we will advertise by FeV1 divided by forced vital capacity into 100. So FeV1 is 4 liter. Forced vital capacity is 5 liter. Then percentage is 80%. 80%. That is the normal healthy adult. FeV1 percentage is 80%. We know FeV1 is 83. So 80 to 85, that which comes under the normal range. So FeV1 percentage is very, very important. It is the percentage that means FeV1 divided by forced vital capacity into 100. Here FeV1 is 4 liter. Means we are inspiring, means expired or a forced vital capacity is 5 liter. But in the end of first second, 80% 4 liter volume of air is breathed out in the first second. So FeV1 is 4 liter. So FeV1 percentage is 4 by 5 into 100, that is 80%. So it is normally in a healthy person, 80% is the FeV1 percentage. So in the next step, patient with obstructive lung disease. What is actually the pathophysiology of obstructive lung disease and restrictive lung disease? Actually, in obstructive lung disease, the problem is with the expiration. Means inhalation may be happen, but the expiration will be difficult. That we know that in bronchial asthma and all, expiration will be difficult. So in the obstruction, tracheobronchial tree, that the obstruction or the constriction that which causes the obstructive diseases. Actually, at the time of obstruction is there, the complete expiration does not occur. So then what happens? Here, forced vital capacity is the maximum volume of air breathed out in a given unit of size. That is the forced vital. So in expiration will be difficult in obstructive diseases. So the forced vital capacity will be decreasing. Okay, will be decreased, and then FeV1 is the air flow rate that we are assessing. So in the end of first second, compared to the forced vital capacity, FeV1 is very less. Clear? FVC is already reduced, and compared to that, FeV1 is also reduced. Okay. Here FVC is 3.2 liter. Just assume that 3.2 liter, and FeV1 is 1.8 liter. So percentage FeV1 by FVC, forced respiratory volume 1 divided by FVC is equal to 0.56, means 56%. Okay, so that is the difference. In a healthy person, FeV1 percentage is 80%, more than 80%. But in a person with obstructive lung disease, it will become less. Here it is 56%. So expiration will be a problem. But in restrictive lung disease, what is happening? Inspiration is a problem. So there will be a problem with the lung fibrosis. Inspiration will not occur, and also with the chest muscle, respiratory muscles problem, paralysis or Guillain-Barré syndrome. In all these conditions, the muscle will not properly working. The inspiration is always active, so the muscles are not working. The thoracic cage, the expansion will not occur, and also the inspiration does not occur properly. So there may be a block, means restriction in the pulmonary expansion. So restrictive, what is happening actually, or almost at the time of inspiration, there is a problem with inspiration, so all the volume will be decreased. Clear? Tidal volume 500 ml will be there, but inspiratory reserve volume decreases. Expiratory reserve volume corresponding decrease may be there. Clear? Here it is 56%, so it is here FeV1 percentage is 56, so it is a obstructive lung disease. That is the difference. Next, come to the maximum mid-expiratory flow rate. Same graph that we can analyze maximum mid-expiratory flow rate. That is the maximum flow achieved during the middle third of the respired volume. That is the expiration graph we can analyze. We can divide it into 1, 2, 3, 4, 25%, 50%, 75%, and 100%. So in between 25% to 75%, that we are called it as maximum mid-expiratory flow rate. That we are also analyzing the same, assessing the flow rate we are assessing. So in between, say 25% to 75%, that graph. So in the mid, we are analyzing, that is the mid-expiratory flow rate. It the pattern shows small airways that indicates this one. Maximum mid-expiratory flow rate. So next comes the respiratory minute volume, RMV. Respiratory minute volume is nothing but this is the volume of air breathed in and out in lungs in every minute. That is the minute volume. Respiratory minute volume. Respiratory minute volume means tidal volume into normal respiratory rate. We are taking 12 to 60. So 12 into 500. That is the 6,000 or 6 liter is the respiratory minute volume. Then we will again subtract the anatomical bed space and all. We are not concerned here. The normal basic concepts I am giving. Next is the maximum breathing capacity. Maximum breathing capacity or maximum ventilation volume. Same again, the maximum volume of air which can be breathed in and out in a lungs by air in a minute. So it comes under the dynamic lung volume. And assessing it in a time within a minute, how much volume of air breathed in and out. Maximum volume of air breathed in and out during a minute is the maximum breathing capacity or maximum ventilation volume. And in males, it is 150 to 170, and in females, so automatically the chest expansion means the size reduced, so it will be reduced in the females. That is 80 to 100 liter per minute, the maximum breathing capacity. So it is reduced in emphysema, airway obstruction, and decreased respiratory muscle strength. Clear? Next, the peak expiratory flow rate. Peak expiratory flow rate. During the expiration, at one point it will the airflow rate will be the maximum. So that we are analyzing it through by using a measure by right peak flow meter that we are using for analyzing this peak expiratory flow rate. It also analyze the important technique that we are analyzing the obstructive lung disease. The flow rate, always the flow rate will decrease in the obstruction. So obstructive and restrictive is the here we are analyzing this peak expiratory flow rate. We can differentiate the obstructive and restrictive lung disease. So next, what are the features of obstructive lung diseases? Features of obstructive: total lung capacity is normal or increased. That we know. In obstructive lung disease, there is no problem with the inhalation compared to the expiration. Problem is there, but compared to the expiration, inhalation is easy. So here, total lung capacity is normal. That is, all the volume of tidal volume increasing, inspiration volume, there is no problem with the inhalation. So the total lung capacity is normal or increased. Residual volume is elevated due to trapping of air inside the expiration. Due to at the time of expiration, what is there? So volume of air that is trapped inside the lungs. So residual volume is the volume of air remains in the lungs after forceful expiration. So the volume of air increases, that is the residual volume increases. Total lung capacity increases, residual volume increases, vital capacity is frequently decreased. Vital capacity is the maximum volume of air breathed out after deep inspiration. So it is decreased because of the block, its obstruction. Vital capacity decreased. And FeV1 by divided FEC, that is the percentage of FeV1 percentage decreases. We saw that in the obstructive cases, FEV1 percentage decreases. And also mid maximum flow, aspirate flow rate decreases. That is, always the flow will be decreases. As we know, in obstruction, the flow will reduce. So this mid aspirate maximum flow rate, that which decreases. These are all happens in the obstructive diseases. So next is the features of restrictive diseases. Restrictive diseases, the expansion of the chest wall, that which decreases, so inhalation will be the problem. So inhalation, already the inhalation problem is the decreased total lung capacity, because the inspiratory reserve volume decreases, expiratory reserve volume decreases, automatically input is correspond to the output. So input is reducing, so the output will be reduced. So all other volume reduce. But the difference is that in obstructive diseases, that the volume that which we are taking and the expiration, that is not it's not compared. Obstruction. 4 liter is the forced vital capacity, and but the expiratory means first FEV1 is very low. But here 4 liter is the forced vital capacity, but the forced respiratory volume will be relative, that is 3600. Clear? But I will show. Just look here. Restrictive lung disease, obstructive and restrictive. Here, restrictive lung disease, FEV1 is 2.7 and the forced vital capacity is 3 liter. So, what is happening here? Restrictive lung disease, the forced vital capacity is 3 liter. Here also, forced vital capacity is 4 liter. That is inspiration is okay. Here, inspiration is affecting. So the forced vital capacity is reducing, but forced expiratory volume is compared. That is similar to that forced vital capacity. Okay, 3 liter is the forced vital capacity, but the forced expiratory volume is only this 2.7 liter. So here what happens? FEV1 percentage is normal or super normal, means more than that of 83%. Here it will come 90%. In restrictive lung diseases, FEV1 percentage is normal or more than normal. Just but in obstructive lung disease, it is always FEV1 percentage is always reduced. 4 liter is the forced vital capacity, but the expiratory first FEV1 is very less. But here comparatively forced vital capacity reducing, so the forced expiratory volume is reducing. That is the change in restrictive lung disease. I think it's clear. Here, decreased total lung capacity, decreased vital capacity, decreased residual volume. So all the volume will decrease. And preservation of forced respiratory flow rates, especially FEV1 as well as percentage, is normal or supranormal. Yeah, that is in restrictive lung disease. So the residual volume, then functional residual capacity. These are not measured by the spirometer. So these are non-spirometric lung volume that we will call residual volume that we can assess through the spirometer. And also, so the residual volume plus expiratory reserve volume is the functional residual capacity. So it is not measured by the spirometer. So all other volumes that we can total lung capacity we can't assess through the spirometer because it includes the residual volume. So all other capacity and lung volume that we can get through this spirometer. Okay, a small time that I gave already. Thank you all for, especially Andrew teacher and producer and all other faculties in the department of PSA. വളരെ സന്തോഷം ഇവിടെ ഇങ്ങനെ ഒരു സെഷൻ എടുക്കാൻ വേണ്ടി പറഞ്ഞത്. എന്തായാലും പുട്ടിന്റെ ഇടയിൽ ഒരു തേങ്ങ എന്നുള്ളത് പോലെ ആ തേങ്ങയാണ് ആ പുട്ടിനെ മുറിക്കുന്നത്. അതുപോലെ തന്നെ സാധനം പറയാം, പുട്ടിന്റെ ഇടയിൽ തേങ്ങ മുറി കഴിക്കുമ്പോൾ ആ ഒരു സുഖം. അതുപോലെ എന്താണ് ക്യാരറ്റ് പുട്ടാക്കാം നമുക്ക്. അപ്പൊ എന്തായാലും ഈ ഒരു ചെറിയൊരു സെഷൻ വന്നതിന് താങ്ക്സ്. താങ്ക് യു.
Thank you, sir. Now the platform is open for discussions. Delegates are welcome to raise any queries if there is any. Please participate actively so that we can learn from.
നാളെ മനോജ് സാറാണ് അതിന്റെ ഇന്റർപ്രിട്ടേഷൻ വരുന്നത് മെഡിക്കൽ കോളേജിൽ നിന്ന്. അപ്പൊ ഈ FEV1 V2 എന്നുള്ളത് അവർ സ്പീഡിൽ പറഞ്ഞു പോകും. അപ്പൊ നമ്മൾ ഇന്ന് അത് ഉറപ്പിച്ചു കഴിഞ്ഞാൽ നമുക്ക് നാളെ സാറെന്ന് പറയുമ്പോൾ സംശയം വരില്ല. ഇപ്പൊ എന്തെങ്കിലും സംശയം ഉണ്ടെങ്കിൽ നമ്മുടെ ഇടയിൽ തന്നെ നമുക്കത് തീർത്ത് പോവാം. ആർക്ക് വേണം ചോദിക്കാം, PG സ്റ്റുഡൻസിനും ചോദിക്കാം, ആർക്കും ഇല്ല. ഏറ്റവും പ്രധാനം എനിക്ക് തോന്നുന്നത് കൃഷ്ണമാർ ഒരുപാട് ഇമ്പോർട്ടൻസിൽ അത് പറഞ്ഞു. കുറെ സ്ലൈഡുകളിൽ അത് ഇത് ഒബ്സ്ട്രക്റ്റീവ് റെസ്ട്രിക്റ്റീവ് തിരിച്ചറിയുക എന്നുള്ളതാണ്. അതിന്റെ ഡിഫറൻസ് തിരിച്ചറിയുക എന്നുള്ളതാണ് ഈ ഇന്റർപ്രിട്ടേഷനിൽ ഏറ്റവും നമുക്ക് വരുന്നത്. ഇപ്പൊ പൂനെയിലൊക്കെ നിങ്ങൾ വായിച്ചിട്ടുണ്ട്, അത് പാരാലിസിസിലാണ് വരുന്നത്, അത് റെസ്ട്രിക്റ്റീവിൽ പോകും. ആസ്മ പോലെയുള്ള സാധനങ്ങൾ ഒബ്സ്ട്രക്റ്റീവിൽ വരും. അതാണ് ഡിഫറൻസ്. അതിനെ തിരിച്ചറിയാനുള്ള വഴിയാണ് ഇത്രയും സാധനങ്ങളിലായിട്ട് പറഞ്ഞത്. നാളെ സാറ് മനോജ് സാറ് വന്ന് പെട്ടെന്ന് പറയുമ്പോൾ നമുക്ക് മനസ്സിലാവണം. ആ ഒരു ബേസ് നമ്മൾ നെറ്റ് വെച്ചാൽ നാളെ സാറ് പറയുന്നത് നമുക്ക് മനസ്സിലാവും. എനിക്ക് തോന്നുന്നു ഇന്ന് വൈകിട്ട് ഒന്നും പോയി വായിച്ചാൽ കുറച്ചുകൂടെ കിട്ടിയത്. അല്ലെങ്കിൽ എന്തെങ്കിലും സംശയം ഉണ്ടെങ്കിൽ ചോദിക്കും. സംശയമൊന്നും ഇല്ലെങ്കിൽ നമ്മൾ നെക്സ്റ്റ് സെഷനിലേക്ക് കിടക്കുകയാണ്. ആക്ച്വലി നോർമൽ ECG എന്ന് പറയുന്ന കുറച്ച് ടൈം ടേക്കിംഗ് കുറച്ച് സമയത്ത് പ്രദീപ് ഡോക്ടറെ കൊണ്ട് അത് എടുത്തു തീർക്കാൻ പറ്റത്തില്ല. അപ്പൊ ആ സെഷൻ നമ്മൾ ഉച്ചക്കത്തേക്ക് ആക്കിയിട്ട് ചെറിയ സെഷനിൽ പറഞ്ഞു തീർക്കാൻ പറ്റുന്ന പീപ്പിൾ സ്പൈറോമീറ്ററും മാനുവൽ സ്പൈറോമീറ്ററും ഇപ്പൊ പറഞ്ഞു തീർക്കാം. അപ്പൊ ഇതിലേക്ക് ലഞ്ചിന്റെ ടൈം ആവും. എന്നിട്ട് ഇപ്പൊ ഉള്ള ആ നോർമൽ ECGയുടെ സെഷൻ നമ്മൾ ഉച്ചയ്ക്ക് ശേഷം ഉച്ചയ്ക്ക് നമ്മൾ 2 o'clock വരുമ്പോൾ ആദ്യം നമ്മൾ